Hello and welcome to our February Facebook Live presentation. I'm Dr. Allison Smith, one of the clinical consultants here at Dutch, and today we're talking about fatty liver and what that looks like on the Dutch test. That's me. If you call me on the phone, this is what I look like, and you're always welcome to get involved in our clinical consults and small group discussions. We enjoy talking about the Dutch test in relationship to many different types of diseases and disorders. Follow our Facebook Live presentations all through, in the last couple of years. We do them every month, so do look through those. This month, we're talking about fatty liver, and we want to discuss non-alcoholic fatty liver, which is a little bit different than alcoholic fatty liver. So we'll talk about the prevalence, presentation, diagnosis, some of the potential results that are affected on the Dutch. And we're going to compare 3 different cases. I thought this would be the neatest way to discuss non-alcoholic fatty liver and how it presents in maybe different populations. We have 2 white females that we're going to talk about who are cycling, and a 49-year-old Hispanic male, all who have been previously diagnosed with non-alcoholic fatty liver disease, and all have various different BMIs in their presentations. And we'll talk a little bit about treatment considerations as well. So what is non-alcoholic fatty liver disease? It's really a 2 or 3 step process. It's initially fat accumulation in the liver that's not due to alcohol use, which alcohol use can contribute to fatty liver. So we have to be able to distinguish between the 2. But non-alcoholic fatty liver is probably even more prevalent than alcoholic fatty liver. And the way we distinguish initially is that the ALT levels are much higher than the AST levels. And it's the opposite with alcoholic fatty liver. A lot of times people will come to our practice already diagnosed with non-alcoholic fatty liver. Most of those guys are in the simple steatosis phase, or I'll refer to it as the SS phase, which may progress into NASH, or the non-alcoholic steatohepatitis phase, where we have a lot of inflammation and fibrosis. And fibrosis is this hardening of the liver that in that phase, when it's early and new, is reversible. But once it progresses into cirrhosis, is not regarded as reversible. It becomes irreversible and leads to end-stage liver disease and sometimes liver cancer, and requires a liver transplant, which is bad news. So non-alcoholic fatty liver may be in this mainly benign presentation for long periods of time. A lot of people never progress into NASH, and certainly not into cirrhosis. And we want to keep people in this reversible phase as long as possible. This is a disease that affects almost 1/3 of our population, so we really want to be vigilant about recognizing it and treating it when we can. It does affect men more than women, and postmenopausal women more than premenopausal women. If you didn't guess, there's definitely an estrogen component to this disease. Estrogen is hepatoprotective. It keeps our hepatocytes free of lipids, and it does play into our risk factors, which we'll talk about soon. But it can still affect adolescents and young adults. Really, anybody can present with non-alcoholic fatty liver disease. But here's the progression, and we touched on a minute ago. It starts with this simple steatosis, which is really just means hepatic fat accumulation. The ALT is higher than the AST, and that's the distinguishing factor between non-alcoholic and alcoholic, aside from what you get from the history from the patient. And in this phase, there is little inflammation, usually. Sometimes people will present with high hsCRP and inflammatory markers, maybe due to other parts of their presentation. Maybe they have metabolic syndrome, maybe there are other pieces that add to the inflammatory piece. But from a puristic perspective, that hepatic fat isn't necessarily driving that inflammation yet until we're in the NASH phase. And in NASH, we have increased inflammatory markers, a lot of pro-inflammatory cytokines, a huge rush to inflammation of the liver. And that inflammation over time hardens the liver, and we get this move into cirrhosis. But In the NASH phase, it's still reversible. So we want to make sure that we take that opportunity to backtrack people into simple steatosis, clear out some of that fibrosis while you still can. And these phases are reversible. So common lab markers that are associated with fatty liver are everything that you would see in metabolic syndrome, interestingly. And they're talking about, at least in some of the articles, about moving from non-alcoholic fatty liver nomenclature into metabolic associated fatty liver. And what that just means is that we're trying to get away from talking about it in terms of alcohol use and get into more the metabolic associations. Because yes, the liver enzymes are high and we have inflammatory markers, but also insulin and glucose and SHBG levels are low and leptin levels are high. All of these things we see with our metabolic syndrome patients. And so you'll often want to screen your metabolic syndrome patients for liver enzymes. A lot of us who aren't doing the primary care for for their functional medicine patients, when you see that metabolic syndrome presentation and you're managing those, it would be good to get your hands on some liver function tests from time to time, just to make sure that ALT isn't climbing up. May influence your treatment plans. Risk factors, as you can imagine, metabolic syndrome is top of the list. Type 2 diabetes puts you at higher risk for fibrosis accumulation and that hardening of the liver that's associated with NASH. So we definitely want to be mindful of fatty liver with our type 2 diabetic patients. Obesity and hypothyroid and PCOS and just about everything that's coming into our office with that hypometabolism can play into a risk factor for fatty liver. And one that a lot of people don't know about is gallbladder removal. A lot of our patients are coming in having had a cholecystectomy. Those guys are established high risk for fatty liver compared to the rest of the population. So screen for that, ask about it. Low estrogen states we talked about. Think about breast cancer survivors who are maybe on aromatase inhibitor supports or male patients who are on aromatase inhibitors. That could put them at risk for fat accumulation in the liver as well. And then people who sit around a lot, sedentary lifestyle does seem to be associated with fatty liver. And there was a study that actually looked at that. And I guess if you sit for, 10 hours a day, if you're sitting for 10 hours a day, you're at X higher risk for fatty liver. That's most of us. So definitely screen for those risk factors. The diagnosis is, it's a little bit tricky. I think because the beginning of the disease is so benign, it's a little blasé in the beginning. You have maybe a lab presentation with a mildly elevated ALT. If you have a mildly elevated ALT a couple of times and your patient's insulin resistant and has a metabolic syndrome presentation, it might make sense to run them through one of the non-invasive lab scoring systems like the fatty liver index or the hepatic steatosis index, and that can help you diagnose initially a fatty liver without going in and doing a liver biopsy or an ultrasound. But often, if you feel a little bit of hepatomegaly or there's some symptoms involved and you're worried, you can always send them out for an ultrasound. It's non-invasive, but sometimes you can see, hyper echogenicity or different findings that would lead you to stage somebody for simple steatosis or even NASH. And then eventually down the road, as you kind of progress, then your patient might be a candidate for biopsy and histology. But the staging can be challenging. And because liver biopsies carry risks, we're not sending people for liver biopsy right off the bat. There are other options for imaging like elastography and other types of fibrosis scores that might be able to kind of lead you to making that biopsy decision. The current conventional treatments I just wanted to touch on because a lot of times we're doing all these supports anyway for metabolic syndrome if that's the presentation, or if somebody has hypertension. A lot of times we're treating different parts of this. The underlying thing may be fatty liver. But this is all that we have. A lot of times people will go home with a prescription for a Mediterranean diet and aerobic exercise for 180 minutes a week. And a lot of times that will, take care of that initial fat accumulation that they're presenting with. Other people need more. They need insulin sensitizers, they need antioxidant therapies and lipid lowering agents. And so it really kind of depends on somebody's really unique presentation. And we'll talk about 3 unique presentations forthwith. Weight loss is an inevitable conversation that we often will be having with patients with fatty liver. You can absolutely have a fatty liver and not be overweight necessarily, but a lot of people who are presenting with fatty liver are significantly overweight and sometimes obese. And so it does become a question of, well, when do we initiate, weight loss pharmacologic agents? And the answer is actually in the medical literature. We do start to think about pharmacologic agents when patients are presenting with comorbidities who have a BMI of 27. That's not obese, that's just overweight, right? In that overweight category. Once we're up to 30 or over, then we're in the obese category, and you can absolutely consider those agents, even if there are no other comorbidities like type 2 diabetes or hypertension. And the goal is really, if you're in the simple steatosis phase, if you can lose 3% of your body weight or 5% of your body weight, that will result in a lot of improvement. But once you're in the fibrosis stage, it really needs to be closer to 10%. So that's when it can be helpful to have the help of some of those drugs. We're not going to spend a whole lot of time talking about the drugs. I want to really focus on some of the lifestyle supports and supplementation. Because we have some good stuff. We have some good stuff in our arsenal. So I want to get into how fatty liver affects our hormones. And I kind of created this little tree because there's a few areas that we find fairly commonly affected in the Dutch test. One is we will see estrogen metabolism shifts. Of course, we have people presenting with inflammation and fat accumulation. All of those things affect our estrogen metabolism and aromatase activity. So we definitely see estrogen metabolism shifts. We also see shifts in cortisol metabolism. This is probably going to be a big focus actually today in this lecture, is how fatty liver affects our cortisol metabolism and how to exploit those changes to help people lose weight and help people's blood pressure come down and really bring down all of those metabolic syndrome inputs, waist circumference, all of that. Inflammation also decreases sulfation activity, and the liver is a big site of sulfation, so we really do see changes in our ability to sulfate, and I'll show you how to look at that on the Dutch. Inflammation and insulin and stress, all the oxidative stress that goes along with fatty liver, increases our 5-alpha reductase activity, so we tend to make the really strong androgens, and that's noticeable on the Dutch as well. And I put melatonin shifts here. The cases that I pulled don't have a lot of change in melatonin. I think most of the patients or all of the patients that I have pulled are in the simple steatosis phase. So the melatonin shifts that happen, metabolic syndrome tends to present with very low melatonin levels in the urine, or low normal. And as fatty liver progresses and we start switching over into fibrosis and NASH, then melatonin levels start to go up, especially with liver enzymes. So if you have somebody with elevated ALT and AST and ALK-Phos and their liver is just screaming mad, often melatonin levels will go way up. And it's endogenous. It's not because they're taking it, it is their body's response. And there's lots and lots of new medical literature on how melatonin can help decrease fibrosis and the inflammation associated with NASH. So there's definitely something to that, even though it's not going to look super exciting on our patients that we're going to talk about today, but just keep that in mind. So we're going to talk about 3 cases. We've got a 36-year-old white female who with a BMI of 50, so significant weight that is probably, pushing her picture. And then we have a 37-year-old white female with a BMI of 35. So in the obese category, but lower on the spectrum. And then a 49-year-old Hispanic male with a BMI of 29, that's in the overweight category. And so they're going to look a little bit different. So let's start with our 36-year-old who is presenting with, she's the one with the BMI of 50, and she desires weight loss. That's her big, her chief complaint is that weight gain. She's never been able to kind of get on top of it. And secondarily, she complains of severe all day fatigue, 10 out of 10 fatigue all day long. She has irregular cycles. She thinks she might have PCOS. And she has been previously diagnosed, as we know, with non-alcoholic fatty liver disease. Ironically, she complains of low estrogen symptoms like hot flashes and night sweats, but she also has a lot of high androgen symptoms like acne and facial hair and mood swings. She has all of those inflammatory markers elevated and liver enzymes, her insulin's up. She's got the pre-diabetic picture. She's currently just using calcium and vitamin D. She's on semaglutide for her pre-diabetes and spironolactone to try to manage the facial hair and acne, but still kind of feeling like she's not managed very well. So let's look at her Dutch. We have a couple findings here right off the bat on page 1 of the Dutch Plus. We can see a couple things. The first thing that I see immediately is an estrogen dominance situation. And I always think about patient symptoms when I'm looking at estrogen levels. And she's got the low estrogen symptoms, the hot flashes and night sweats, yet her estradiol is very high. And it's high compared to the progesterone. And so this already is kind of looking like maybe a tachyphylaxis situation. If your estrogens are high and your tissues are sort of hiding from all that estrogen, that could end you up with a pretty low estrogen presentation. So maybe that could be an area to help with those hot flashes and night sweats, thinking about lowering those estrogens. And where are those estrogens coming from? Probably these high androgens, very high testosterone off the charts. DHEA production is off the charts high. And metabolized cortisol is off the charts high. Profound estrogen dominance, extremely high androgens, and this huge shift of cortisol into the liver. So metabolized cortisol is cortisol that has been taken up by the liver and adipose tissue and has been cleared through that tissue. So I think of metabolized cortisol as liver cortisol in a way. And we can see that the needs of the liver and the adipose tissue exceed that which she can manage to keep in circulation. So that's remarkable. Page 3 of her Dutch Plus is a deeper dive into the estrogen metabolism and the androgen metabolism, both of which are affected by fatty liver. We get the lower sulfation. So you can see her DHEA sulfate is 65. And this exists on an age range. So 60 to 750 is what we expect to see for somebody who's in their 30s. She's at 65. That's pretty low, especially compared to her downstream metabolites of DHEA, which are screaming off the page. Androsterone is very, very high. So when we think about her total DHEA production, it's high, but her DHEA sulfate is low normal. That might tell us that she's got a hyposulfation going on there. 5-alpha reductase activity is pretty excited. So really, that's pretty obviously weighted towards androsterone. And we know that insulin, inflammation, and stress all drive 5-alpha reductase activity. No surprise there. And then in the estrogen metabolism, here's her little aberrant E2 metabolism. You can see it really well in the pie chart. That pie chart is not supposed to be so blue. It's supposed to be very green, mostly green. And we can see that her 16-hydroxy is very high compared to the 2-hydroxy metabolite of estrone. The 2-hydroxy is the one that makes up the green part of the pie. So we really would like to rearrange this activity for her. Inflammation and obesity drive all of these patterns. Inflammation drives the hyposulfation of DHEA, and the 5-alpha reductase preference is both obesity and inflammation. And obesity drives that 16-hydroxy pathway as well. High androgens, we know. I just want to throw in too, because the female presentation of fatty liver is tends to be androgen dominant, right? It's associated with visceral adiposity and insulin resistance. So it's really different than the way a male would present with visceral adiposity and insulin resistance. It's totally opposite with low testosterone, which we'll see. So that's why I wanted to make that note there. Those androgens here, really, really high, associated with visceral adiposity. All right, so here's her page 5 and kind of a recap of her adrenals. And we know that her DHEA production is up, but her DHEA sulfation is low. She's got kind of a low normal melatonin, so she doesn't look like she's got the, high melatonin herald of steatohepatitis. She looks to still be in this simple steatosis phase of fatty liver. But we do see her metabolized cortisol much higher than her 24-hour free cortisol down here. And this is an important shift here. Early in fatty liver, we do get a big shift into the tetrahydrocortisone, the THE shift, flop over to the left in this fan gauge with the simple steatosis phase of fatty liver. And we're going to see that across the board with all of our patients today. All right, now we have our 37-year-old, and we'll look at all of these side by side, don't worry. Now we have our 37-year-old female. She has weight gain, she's BMI of 35, also has fatty liver. Her presentation's a little bit different. Her cycles are regular, but she does takes the medications for her fatty liver. She's using some NAC and glycine, selenium for that glutathione system, and some vitamin D. And she's not using any medications as of yet. So already, her test summary looks a lot different than the last patient's. There's nothing jumping off the page, nothing bright red and hugely high, but we do see that same kind of relative estrogen dominance where these estrogen and progesterone dials are pointing to each other essentially. And she looks to have not ovulated, interestingly, for somebody who's got regular cycles. This looks more like an insufficient luteal phase, possibly. Testosterone or an anovulatory cycle, or maybe we caught her in the wrong time. Testosterone looks much more normal than the last patient, and the DHEA also looks pretty normal for age, right? If anything, kind of on the lower end of range. But she still has this free cortisol total being a lot lower compared to the metabolized cortisol. You can see those gauges starting to point away from each other, and that flattened cortisol pattern that we appreciated with the last patient. So there are some little signs that we see that are consistent across both. So there's that low sulfated DHEA. We have a slight 5-alpha preference. You can see hers is less pronounced than the last patient, and maybe it's because she is perhaps less of an insulin picture than the last patient. Maybe she just has the inflammatory underpinning, more inflammatory, less insulin, and that'll help us pick a therapy, protocol for her, and maybe we'll focus more on the inflammation more than insulin. So these are all things you can glean from the Dutch. She does have an engagement of the 4-hydroxy pathway rather than the 16. She's got 14% of her metabolism headed down to the 4-hydroxy metabolites. And even though she's a good methylator, she's still not moving through the 4-hydroxys as well as we would like. And this 1B1 pathway is upregulated by, you guessed it, inflammation. So she has much more of a pure inflammation picture rather than like the insulin picture per se. So here's her page 5 of the Dutch Complete. And she does have the low melatonin. Metabolized cortisol compared to the free cortisol, much higher, right? Flattened out free cortisol pattern, much more normal looking metabolized cortisol. But she also, just like our last patient, has that big tetrahydrocortisone shift that we know occurs with fatty liver and early phases of fatty liver. And she had a low sulfation of DHEA as well, so compared to her etiocalanolone and androsterone. So she does have that inflammatory suppression there of sulfation as well. Here's the side-by-side comparison. And when we're done with the male case, I'll have all three of them kind of laid out. But I think, even before we go into his case, we can see some similarities. First we see the shift into the cortisone metabolites in the fan gauges there, pretty profound, and the flattening of the cortisol patterns, So just kind of waking up low, and just lows across the board, really, overall in the free cortisols compared to the metabolized. So interesting. So here's our 49-year-old male, Hispanic male. He complains of weight gain, and he's got a higher BMI, but not in the obese category at this point. He has been previously diagnosed with fatty liver. His presentation is very much in the high blood pressure, high lipid, panel. His triglycerides are in the 800s. There may be kind of a familial component here, but he definitely has inflammation and his liver enzymes are mad. He is currently taking fenofibrate, which is a drug designed to decrease triglycerides and increase their elimination. And there may be some effect of fenofibrate on sulfation, and I'll show you on the report how that looks. And he's also on lisinopril, which can influence our free cortisol conversion to free cortisone. So all those may have an influence on what we see. So on his report, on the male reports, we don't concentrate so much on progesterone to figure out estrogen dominance, but we look at estrogen compared to testosterone. And we do see he has a relative estrogen dominance too. His testosterone is low, frankly low, really for any age. Even if he was 89, that would be low. And he also has this big shift of cortisol out of circulation and into the liver metabolism. So that all stands out as consistent with some of the other cases that we've looked at. So let's unpack this. Page 3 of the Dutch Plus. And here's where we can look at his DHEA sulfate right up here and compare it to his downstream metabolites of DHEA. He doesn't look to have a sulfation problem at all. And my guess was that this was a fenofibrate effect. Fenofibrate is a PPAR alpha activator, and that leads to lipolysis and triglyceride elimination. It also increases, and this is the link to sulfation, it also increases bile acid glucuronidation, and it increases chenodeoxycholic acid. And CDCA, or chenodeoxycholic acid, upregulates the promoter for all of our salt enzymes, especially SALT2A1. So it's possible that that increase in the CDCA could be upregulating the sulfation of DHEA. And maybe that's why he looks so normal here, possibly. So we got to look at what patients are taking and how that might be influencing the test. Here, the testosterone is low. We know that low T correlates with fatty liver development, kind of the opposite of that effect in women, where high testosterone may be more correlated with fatty liver development, interestingly. 5-alpha and 5-beta reductase looks pretty balanced. So maybe his BMI is working for him. There's not so much of a big 5-alpha preference as we saw in the last two patients who had the higher BMIs, more insulin inflammation effect possibly. But he does have this high 16-hydroxy prevalence, high 3A4 activity that we do see with inflammation often. The pie is pretty blue, shouldn't be that blue. So there are lots of ways we can influence estrogen metabolism and put him at a little bit of an advantage. And it's interesting, if you type in, go to PubMed and you type in pretty much anything that affects estrogen metabolism and fatty liver, you can usually find a study that says that improves hepatic fat accumulation, including DIM, including green tea. So all the things that we think of for estrogen metabolism tend to be helpful for fatty liver. Let's look at his adrenal profile. And he's got a lot of the same presentation, although his melatonin looks better than the other two. DHEA production, remember, looks okay, probably the fenofibrate influence, but he definitely has this metabolized cortisol higher than the free cortisol. But I do want to point out Oh, and this shift towards the tetrahydrocortisone, very much preserved across all 3 patients. But I do want to point out the difference between the salivary free cortisol and the free cortisone. And this is very much consistent with patients using lisinopril. And the reason is that free cortisol and free cortisone, or at least the free cortisone in saliva, is formed in the salivary gland, which is lined with mineralocorticoid receptors. And that tissue has a high type 2 form of the 11 beta HSD enzyme, which we're going to talk about a little bit more today in detail. That enzyme converts cortisol to cortisone right there in the salivary gland. And that enzyme is also active in the kidney, where we're looking at urine. It's all coming through the kidney. So free cortisol, free cortisone balance is going to favor cortisone in patients who are on blood pressure medications like lisinopril, losartan, hydrochlorothiazide. We'll see a shift over into this cortisone metabolite, and because that's one of its kind of side effects of that class of medications is a shift in that enzyme activity. So you would really look to the free cortisone to give you a better idea of how much cortisol is coming into the salivary gland at each time point, and it's significant. He's high normal throughout the day, so we wouldn't necessarily look at his test and say, man, his free cortisol patterns are flattened out. He actually looks a lot more normal than our other patients did, and but he's nowhere near the metabolized cortisol, which is really, really high, right? So he still has that high metabolized cortisol compared to the free. All right. So here's our 3-way comparisons. We've got our aberrant estrogen metabolisms. 2 of them are favoring the 3A4 pathway, which is upregulated by inflammation and obesity. And then our 1B1 activity is upregulated in our middle patient here. So definitely some aberrant estrogen metabolism happening. We also have our hyposulfation in our 2 patients who are not on fenofibrate therapy. And then our estrogen dominance, which is pretty clear here. High estrogen, low beta preg, high estrogen, low beta preg, high estrogen, low beta preg, or testosterone, testosterone. So that stands out as consistent. And then we have this weird, anyone notice this high COMT activity on all of these? I don't know what that means necessarily. I thought that there might be an association, and I still think that there could be possibly, but this seems a little bit ahead of the literature. So I would say let's notice that and put a pin in it and keep scouring the literature. But all of these guys tend to have these higher COMT activities in phase 2 metabolism. 3-way comparisons for the adrenal hormones. We've got all of them have the tetrahydrocortisone preference, and really kind of a high metabolized cortisol for these 2 patients. The one in the middle has a little bit more of a volume turned down metabolism of cortisol, but definitely that shift into the cortisone metabolites. And we have the relative difference between the metabolized cortisol and the free cortisol patterns. So free cortisol a lot lower than what we're seeing processing through the liver. So kind of back to our how fatty liver affects our hormones, and we got to see that in 3 patients, and how that might affect the labs. And not everybody has all of these. So, but we want to kind of treat what we see. Maybe the 5-alpha reductase activity is being normal, tells us that maybe there's less of an insulin influence and more of a pure inflammation influence. But if you have somebody who has all of those inputs together, everything might be screaming high, like our first patient. So really kind of put it together with the patient's presentation and go after each area as you feel comes out on the Dutch. So I want to kind of flesh out the effects on each area. We see increases in liver and fat cortisol metabolism, right? That shift of 24-hour free cortisol being low, cortisol is moving into the liver and getting metabolized there. And that makes us lose our diurnal free cortisol patterns. And once we lose our diurnal free cortisol patterns, then it's hard to regulate our peripheral body clocks, which are listening to our rise of free cortisol through the morning and the drop through the day. That's our diurnal rhythm for leptin and ghrelin and adiponectin, and a lot of our adipokines and other hormones are listening to the cortisol diurnal pattern to know when to come up and come down. Interleukin 6, there are a lot of downstream consequences to losing our diurnal patterns. So cortisol moves into the liver and adipose tissues, and we get that shift in cortisol metabolism toward the inactive cortisone metabolite, tetrahydrocortisone. And you can see that shift really easily in those reports. And I think it's important to distinguish what form of the 11-beta-HSD enzyme is being expressed in the tissue we're interested in. With fatty liver, we're interested in fat. We're interested in the fat. The adipose tissue expresses the type 1 form of 11-beta-HSD. And the things that drive this enzyme activity up are insulin and leptin resistance, inflammation, and stress. Like the holy trinity of functional medicine is inflammation, stress, and insulin. It's what we're always treating, I feel like, is this enzyme in a way, or the inputs into this enzyme. This enzyme reactivates cortisone, inactivated cortisone. It's quiet, it's minding its own business, and it turns it back into active cortisol. And when it does that in the adipose tissue, it stimulates lipogenesis, adipocyte proliferation. And this happens in the visceral fat in particular, visceral fat, liver fat, omental fat, central fat, 11-beta-HSD type 1. So that could be a target. And I think a lot of people are noodling about how to target 11-beta-HSD1 to help with lipolysis and freeing the liver of hepatic accumulation. But what happens when we progress to NASH? We get a little bit of a different cortisol clearance. I was going to present this case too today, but it seemed like too much. But you can see a big shift of cortisol. It's still shifted into the liver and the adipose tissue, but you can see this shift over into the cortisol metabolites, the THF metabolites, and that suggests that there's an acute inflammation. Anybody who's used to looking at these fan gauges knows that if you're flopped over to the right in the fan gauge and you're favoring active cortisol THF metabolites, it suggests an acute stress, acute inflammation, acute immune, this is happening. So this is much more consistent with the progression to NASH. And this may just be due to the acute inflammation. There are treatments that we have in our arsenal that can target 11-beta-HSD type 1, possibly. So we always want to be a little bit careful with inhibiting 11-beta-HSD type 1 during the NASH stage, because it can decrease our body's ability to use cortisol as an anti-inflammatory. So if you were only using an 11-beta-HSD type 1 inhibitor without any anti-inflammatory support, you could advance fibrosis, theoretically. So with NASH, we try to go with more general anti-inflammatories and insulin sensitizers. Luckily, all of our botanical 11-beta-HSD type 1 inhibitors are also very broad spectrum. They tend to be anti-inflammatories as well. So we'll talk about that when we get to them soon. So this is just a little recap. Tissue cortisol and cortisone is governed by, governed by the tissue that it's in. So if we're in the kidneys, we're in the colon, we're in the salivary gland, it's 11-beta-HSD type 2, which inactivates cortisol to cortisone. It happens to be the dominant enzyme in obesity in those tissues. So we want to make sure that an overstimulated cortisol to cortisone is hopefully stemmed. There are ways to do that. Licorice is kind of our go-to in those cases. And the reason we might want to do that, and I'm still trying to understand cortisol and cortisone and how it may or may not be reabsorbed and redistributed through the body. But I did read an article that suggested that cortisone could be reabsorbed at the distal tubule and go straight to the liver and add to our cortisone pool to be reactivated to cortisol. So if you're inactivating cortisol to cortisone in the free, when we're looking at the diurnal patterns, we're looking at that free cortisol and free cortisone. I'm thinking of our male patient with the lisinopril on board, where he's converting over into cortisone. If he's doing that in the renal tubule and reabsorbing that cortisone, and that cortisone is going to the liver, could that be adding to part of the problem and fueling the fire of his adipose tissue accumulation in the liver? So I think, we want to pay attention to not only the type 2 form right there in the adipose tissue, we also want to pay attention to that balance for what we see between free cortisol and free cortisone too, right? It matters. It's more than just headed out of the body in the saliva or in the urine. Some of it might be reabsorbed. 11 beta HSD type 1 in the adipose in the liver, where we're really interested in talking about today. That's the one that reactivates cortisone to cortisol. It's activated by inflammation and insulin, and in metabolic syndrome is all full of inflammation and insulin. So we can imagine that 11 beta HSD1 is pretty upregulated in that population. Sulfation, we saw that the low SALT2A1 might lead to lower DHEA sulfate levels, and we know DHEA sulfate levels tend to decrease with fibrosis stage. So as we go through into cirrhosis, we get less and less and less DHEA, and DHEA sulfate in particular. 5-alpha reductase activity is upregulated by the Holy Trinity: stress, insulin, inflammation. Visceral fat is innately inflamed and insulin resistant. It emits adipokines like leptin and pro-inflammatory cytokines like interleukin-6 and TNF-alpha. So a lot of times, if we want to decrease 5-alpha reductase, we have to go after inflammation or insulin sensitivity, and that's the thing that brings down that 5-alpha reductase activity. There are 5-alpha blockers, certainly, but if you can go after the source, you can get a more broad spectrum result as well. We've seen its effect on estrogen and metabolism. We know low estradiol is an important risk factor for the development and progression of non-alcoholic fatty liver disease. Women and men, possibly. There seems to be two different effects with estrogen. So with women, if your estrogen's low, you're at higher risk. Same thing for men, but men have the added issue with testosterone. So if their testosterone is low, that can cause progression of fatty liver for women, or is associated with progression of fatty liver, I should say, not necessarily cause. And then in women, high testosterone seems to correlate in with those metabolic insulin resistance and inflammation that leads people to more hepatic fat accumulation. So high T for women, bad; low T for men, bad. Estradiol is protective to hepatocytes. We know that estradiol increases the enzyme PEMT, which helps us form phosphatidylcholine in the liver. And some of us who have been around the block for a while know phosphatidylcholine can melt liver fat. So phosphatidylcholine is super important. Estrogen protects our phosphatidylcholine. 3A4 activity and 1B1 activity we saw upregulated for different reasons in different patients. We want to alleviate whatever is driving those pathways. If it's obesity, and we want to get some body mass loss. If it's inflammation, we want to go after the inflammation. Usually it's a combination of several things. But if you can go after those things, you can decrease those 4-hydroxyestrogens that are so genotoxic. And then this is the link with melatonin levels. So low melatonin we often see with a myriad of disorders that are related with fatty liver. But I would say the most interesting thing that I'm finding just reading about melatonin is this rising high melatonin being associated with high liver enzymes, ALT and AST in particular. When they take a northward turn, melatonin levels go up in the urine. They also go up with fibrosis, increased fibrosis, which we tend to see high liver enzymes when that happens too. So that might be your first sign. So look for that. So our functional medicine management of fatty liver is usually go after the inflammation, the oxidative stress, the insulin resistance, and then there's some conjecture about the value of balancing the sex hormones. And I would say it's arguable that balancing the sex hormones could be the icing on the cake for some people. So we will talk about that. So under the inflammation side of things, we want to balance cortisol and cortisone in the liver fat. We want to encourage cortisol activity when it arrives to the tissue. It's there for a reason. If it's getting converted over into cortisone, it might make sense to work to inhibit that in some cases. Licorice extract is our treatment for that. Licorice carries the risk of high blood pressure in patients who are desperately trying to limit cortisol's mineralocorticoid receptor exposure. So, for somebody who's already kind of in a fragile state with blood pressure, licorice can send them over the edge and cause problems. It can also cause hypokalemia. So we always want to monitor our patients' chem panels for electrolyte levels when they're on licorice fairly regularly. So that's always the caveat with licorice, but it can be a really great way to keep cortisol from converting into cortisone robustly in a patient who has a strong cortisone preference and who may be possibly reabsorbing that cortisone at the distal tubule and sending it right to the liver to fuel what we're trying to stop. And then the other part of it is to come around and break the cycle of reactivation of stored cortisone in the liver fat and stop it from reactivating to cortisol. This can stop lipogenesis. So if we want to inhibit the type 1 form, the herbs that have been studied for this, for inhibiting 11 beta HSD1, and these are all preclinical studies, mind you. So these are not, human randomized controlled trials that established a, 11 beta HSD type 1 inhibitor status, but these all have been studied for their effects in vitro for inhibiting this enzyme. They are bitter melon, curcumin, and green tea extract. I did include kind of some dosing from studies that I have here on this next page. So from these studies, I'm just kind of giving you the primary endpoints for dosing strategies that do affect liver enzymes. So in that way, it may be helpful to kind of frame what you might use for somebody to inhibit this enzyme. And there are documented phase 1b human drug trials out there that have assessed 11 beta HSD1 inhibitors for the treatment of fatty liver in particular. So I would say look for those drugs to come out in the future possibly, but they do demonstrate promising results for reducing liver fat content. So the other piece, well, a couple more pieces of addressing inflammation is to restore that diurnal pattern. So once you decrease the liver and adipose need for cortisol by addressing inflammation, insulin resistance, and oxidative stress, and that metabolized cortisol starts to come down, then we can encourage that diurnal variation, right? So now you're going to have some free cortisol to work with. It's not wicking out of circulation as soon as you can make it. So if we encourage the diurnal variation, the morning rise and afternoon fall, then we can start getting some weight loss going. Light therapy, intermittent fasting, adaptogens. I'm not going to go into adaptogens this time, but they can be wonderful for kind of reestablishing the HPA axis negative feedback. And then we have a lot of direct ways of addressing inflammation that work to decrease interleukin-6 and TNF-alpha. and decrease liver enzymes and bring down BMI. And I tried to include the highest yield ones and the most promising ones. And phosphatidylcholine's first on the list. Curcumin is popular for this. There are a couple of case reports in the medical literature about curcumin causing autoimmune hepatitis. So I think, if people are just pulling curcumin off the shelf and are using it and don't really know why they're using it and they're not monitoring, that can be problematic. But, if you are monitoring your patient on curcumin, you should be hip to any possible changes that come about. Curcumin typically lowers severity grade of fatty liver, and it decreases ALT and AST at pretty moderate doses. Talking about like a gram a day of the liposomal. So not bad. Systemic enzyme therapies work better for men than they do for women, and that's the bromelain, trypsin, rutin, wobenzyme type formulas. They tend to reduce CRP and interleukin-6 in men, somewhat in women, but not as significant. Pentotal, 300 to 500 milligrams, studies pretty well for changing liver fat content, and that can also help with insulin. Mushroom extracts have a little bit of traction behind them, and naringenin, going to keep my eye on. It's one of our polyphenols from oranges, and you can get some pretty good changes in 4 weeks, in fact. So definitely thinking about some of those anti-inflammatories as part of the regimen. Then we want to restore insulin sensitivity, and this is always a goal. I feel like even when you don't think it's going to be. And I just included some of the big ones that have some crossover benefit for fatty liver, and they're berberine in particular been looked at with fatty liver, and bitter melon I have on the 11 beta HSD type 1 slide, so you can look at that for dosing ranges. But chromium has been looked at for fatty liver, and so has myo-inositol. So lots of ways to work insulin and also get that side benefit for lipids. And then stress, getting on top of oxidative stress, all of those liver-specific glutathione helpers, NAC, glutathione, selenium should probably be on this list. I included the melatonin here because the mid-level dosing, 5 to 10 milligrams or so of melatonin used nightly, studies really well for lowering triglycerides and cholesterol and decreasing waist circumference and leptin levels, but also liver fat, steatosis. And vitamin E is even used in the conventional medical world, in that 400 to 1,000 IUs kind of dosing range, even in the long-term studies of use. And they often will use it with vitamin C. So you can get some improvement in liver histology. For the sex hormone part, it's a little bit trickier if you're not testing patients and you don't know where they're at. But if you're doing the Dutch, you have some idea of whether or not somebody's coming in with a low estrogen and they're female, or they're coming in with a low testosterone and they're male. And you can start to weigh out some of the risks and benefits with starting hormone replacement therapy. In women, we kind of want to help estrogen and modulate androgens. In men, we kind of want to help the androgens, want to help the testosterone, and there are some benefits to doing that. I know with women, there's starting to be a shifting focus more into transdermal ERT, but I would say the studies that are looking at fatty liver, we're really looking at oral estrogen, oral estradiol in particular. But NAMS is kind of they're in a holding pattern when it comes to recommending it for fatty liver, even though it does confer benefits against fibrosis. So I would say, if you're prescribing estradiol to your postmenopausal female based on the fact that they have fatty liver, you might not completely have a leg to stand on, but it may improve outcomes, and it might be something that you could do safely while you're monitoring. And there's that high androgen connection too for development of fatty liver in younger women. If you have high androgens, it is associated with fatty liver development. And there was a study that looked at low-dose spironolactone, which really is working on mineralocorticoid receptors, but it also has this benefit, the side benefit of being an anti-androgen. And when patients use spironolactone with vitamin E, it's studied really well for decreasing the liver fat score, better than vitamin E alone. So there's something there. For men, they tend to have low testosterone in the presentation of fatty liver. There have been a couple of really big, gorgeous long-term studies that have looked at testosterone replacement in that the giant 1,000 milligram T and decanoate studies where they, give you a 12-week shot that lasts you 3 months. Really uncomfortable, but it can decrease a lot of the inputs like BMI, waist circumference, and improve liver function tests in patients with fatty liver. So really, really promising. And then there's all these wonderful phytoestrogens we can't forget. Trans-resveratrol has been looked at for improving hepatic echogenicity on ultrasound. It's pretty much every input into fatty liver known to man, it improves. Even in the low dose treatment groups, 50 milligrams, that's doable. So possibly trans-resveratrol. Here's the licorice information I promised you. There are a couple studies that have looked at licorice as an effective way to decrease ALT and AST. And they're using pretty big doses, 2 grams for 2 months. That's a pretty good lead dose. You would definitely want to monitor, electrolytes. And then we have the soy isoflavones. I kind of expected genistein and diazine to show up here, and genistein does, certainly. But there was a soy milk study that they had patients on a 500 calorie deficit diet, and they had them drinking 120 mils of soy milk a day, and they had these changes to their fatty liver profile, and their inflammation markers went down. So that seems like an easy thing to incorporate, make a big difference for somebody. And here's all those references that go with those. And I do want to focus, or at least end on diet here, because this seems to be the foundational thing, I would say, for patients with fatty liver disease. And if this piece isn't in place, you might be spinning your wheels, even with supplementation. And the trick seems to be, across all of these diets, the trick seems to be plant-based proteins and polyphenols. So focus there. I thought this green Mediterranean diet looked interesting. They got some really amazing results. This polyphenol amplified Mediterranean diet with walnuts and green tea, and anyway, so keep an eye out for some of these newer diets that may be coming out that might help your patients get there faster. Even seemingly small adjustments can reverse fatty liver. So I think that is the biggest takeaway, biggest thing that I learned is that, I think this is an important condition because people are presenting and it is potentially serious down the road, potentially cirrhosis, potentially liver cancer. Big deal. This is an important time for us to be able to really help get patients on the right road, and side benefit for weight loss and looking better and feeling better. And so start small and work your way out, and those benefits will resound. Thank you so much for listening. Feel free to email me questions to Dr. Dutch at dutchtest.com, and follow us, leave a review, talk to us, get in for a consult. If you have questions, I hope to hear from you. Thank you so much.